Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
When you first look at the pharmacology of Parkinson's disease, it can feel like you're just trying to memorize a huge, disconnected list of drugs. But what if there was a better way? What if you could understand the entire field through just a single core concept? Well, that's exactly what we're going to do today. We're going to build a mental framework, not just a list, so you can reason your way through any exam question that comes your way. Let's get started.
When you see the classic signs of Parkinson's, that resting tremor, the rigidity in the limbs, the stooped posture, that shuffling walk, you're really just seeing the downstream effects of a very specific failure in the brain's chemistry. These aren't separate problems. They're all clues pointing back to one single molecule.
And here it is. This is the absolute heart of the matter. Parkinson's disease is fundamentally about the loss of dopamine-producing neurons in a part of the brain called the substantia nigra. As these neurons die off, the brain simply doesn't have enough dopamine to function correctly. This single fact, this dopamine deficiency, is the key. It's the central problem that every single drug we're about to discuss is designed to fix.
So here's our game plan. We'll start with the main event, the levodopa strategy. It's the gold standard. Then we'll look at the supporting cast, the drugs that make our star player even more effective. After that, we'll explore a different approach that bypasses that main pathway entirely. We'll also touch on a fascinating outlier, amantadine, and then we'll lock it all in with a high-yield exam review to make sure it sticks.
Okay, so if the brain is missing dopamine, the most logical first thought is, well, why not just give the patient dopamine? Seems simple, right? But this is where we run into our first major pharmacological hurdle, the blood-brain barrier. It's like a highly selective security guard for the brain, and it flat out refuses to let a molecule like dopamine pass through. So we have to get more creative.
And this is where pharmacology gets really clever. The solution is levodopa, or L-dopa. Think of it as a Trojan horse. L-dopa is the direct precursor to dopamine, and unlike dopamine, it can get past the blood-brain barrier. Once it's safely inside the brain, the surviving neurons have the necessary enzyme to convert it into the dopamine that's so desperately needed.
But there's a huge catch with our Trojan horse strategy. The very same enzyme that converts levodopa in the brain is also found all over the rest of the body, especially in the gut and liver. And what that means is a staggering 95% of the levodopa you take orally gets converted into dopamine before it even has a chance to reach the brain. Think about that. It's a massive amount of waste.
Now, this isn't just inefficient. It's the direct cause of some of the worst side effects. All that dopamine floating around outside the brain triggers nausea and vomiting. It can also act on the heart, causing things like arrhythmias. So to make this strategy work, we absolutely have to protect our levodopa on its journey to the brain.
And this is where carbidopa comes in as the hero of the story. Carbidopa is the perfect bodyguard. Its only job is to inhibit that enzyme, dopa decarboxylase, that converts levodopa to dopamine. And the brilliant part of its design is that carbidopa itself can't cross the blood-brain barrier. So it only works in the periphery, right where we need it, leaving the brain's machinery to do its job untouched.
So let's trace this journey step by step. First, levodopa and carbidopa are given together. Second, out in the periphery, carbidopa acts as that bodyguard, blocking the conversion of levodopa. Third, because it's protected, a much higher percentage of levodopa actually makes it to the brain. And finally, step 4, once it's safely inside, levodopa gets converted to dopamine. It's a truly brilliant synergy.
All right, we've successfully boosted the amount of dopamine being made in the brain. That's a huge win. So what's the next logical step? Well, now we need to protect that newly made dopamine and make it last as long as possible. Let's look at the drugs that help us do that. Let's use this diagram of the synapse as our map. We've been focusing over here on the presynaptic neuron, getting levodopa inside. Now our attention is going to shift to the two main enzymes that break down dopamine. One is called MAOB, which is inside the neuron, and the other is COMT, which is found both in and out of the neuron. Our next drug classes are designed to inhibit these guys.
First up, we have the MAO-B inhibitors. The prototype drug you absolutely have to know for your exams is selegiline. Now, MAO comes in two main flavors, A and B. MAO-B is the one that's primarily responsible for breaking down dopamine in the parts of the brain affected by Parkinson's. So by selectively blocking MAO-B right inside the neuron, selegiline essentially prevents dopamine from being destroyed, which means more of it is available for release.
Next are the COMT inhibitors, with entacapone as our prototype. Now, COMT is interesting because it works in two key places. Out in the periphery, it breaks down levodopa, reducing the amount that gets to the brain. And then inside the brain, it helps break down dopamine itself. So by inhibiting COMT, drugs like entacapone give us a 2-for-1 benefit. They help more levodopa reach the brain, and they make the dopamine that's already there last longer.
So everything we've talked about so far depends on the brain's remaining neurons being able to convert levodopa into dopamine. But as the disease gets worse, there are fewer of those neurons left to do the job. So what if we could just skip that step completely? This brings us to our next class of drugs.
Okay, back to our map of the synapse. We're now going to jump across that gap, from the presynaptic neuron to the postsynaptic neuron. We're no longer focused on making or releasing dopamine. Instead, we're going to target the dopamine receptors directly, those structures on the other side that are built to receive the dopamine signal.
These are the dopamine agonists. Your prototypes here are drugs like bromocriptine and ropinirole. These drugs are designed to look and act just like dopamine. They bind directly to those postsynaptic receptors and turn them on, mimicking dopamine's effect. The key advantage here is that their effectiveness doesn't depend on those dying neurons at all. They just bypass the problem, which is why they're often used in younger patients or later on as an add-on therapy.
Now let's talk about a bit of an oddball, amantadine. This drug's role in Parkinson's was discovered completely by accident, and even today, its mechanism isn't perfectly understood, which makes it a really fascinating case.
The story of amantadine is pretty wild. It was originally developed as an antiviral drug for the flu. Its anti-Parkinsonian effects were a complete surprise. The leading theory is that it works by encouraging the presynaptic neurons to release more of their stored dopamine. It acts really fast, but its effects are pretty mild compared to levodopa, and unfortunately, patients often develop a tolerance to it over time.
Okay, we've covered the individual players. Now, it's time to pull it all together and synthesize this information into a high-yield framework, organizing it exactly how you'll need to recall it when you're staring down an exam question.
All right, let's do a rapid-fire review. First, levodopa/carbidopa. That's our dopamine precursor plus its bodyguard. It's the absolute cornerstone of therapy, designed to maximize brain delivery and minimize side effects. Second, MAOB inhibitors like selegiline. They stop dopamine breakdown inside the neuron, making levodopa work better and last longer. Third, COMT inhibitors. These are add-on drugs that stop the breakdown of both levodopa in the periphery and dopamine in the brain. And finally, the dopamine agonists. They skip the line and go straight to the receptors, an action that is completely independent of the brain's ability to make dopamine.
So let's close with a clinical challenge to get you thinking. Imagine a patient who has been on levodopa/carbidopa for years, and now they're experiencing these frustrating on-off periods where the medication works for a while and then suddenly stops. This happens because of levodopa's short half-life. So based on the mechanisms we've just discussed, how could adding an MAOB inhibitor or a COMT inhibitor help smooth out that response and give the patient more on-time? Connecting these core concepts to clinical problems, that's the final step to truly mastering this topic.